Fara-Erny is the Associate Chief Nurse for Operations at IU Health Bloomington Hospital. She has a clinical background in critical care and has been both a CNS and an acute care nurse practitioner. She completed her DNP at UIndy this spring, and her project focus, for which she won the Lambda Epsilon Research Award at graduation, was on nursing incivility. So please join me in welcoming Dr. Fara-Erny.
I'm not used to that Dr. Fara-Erny yet. It's still kind of like, who's that? Who is that? So thank you, and I so appreciated the award. It was an absolute shock. I didn't expect it. They kind of snuck it up on us while we were sitting in that front row at the pinning ceremony. But it was a lovely surprise. And the honorarium, the gift for that award is going towards this work for where I'm working at now. We're going to be doing some educational programs around this type of work. So I hope you enjoy a little bit of what I've got to tell you about. It's continuing on a little bit. I just started my role at Bloomington 6 months ago, so I'm trying to get my feet under me. I feel kind of anxious to get back started with some of this, and that's beginning now. So I look forward to continuing some of this work. And I would enjoy hearing some of your thoughts as educators, because I have seen recently in the literature that I've read that there's a bit more that can be done about this in simulation and in teaching nurses and supporting their comportment or their way of handling situations. We'll talk about that a little bit. We have a retreat coming up for our nurses in Bloomington, and that's some of the things that we're going to start talking about and spending some time on. So I hope you enjoy a little bit of this. So I took this on as a project. My project site was IU Health West Hospital in Avon, Indiana. I was there 8 years before I graduated and got this promotion for Bloomington. And the chief nurse and I were really distressed by our turnover. We had significant turnover in our hospital. We had a lot of, I'm fighting a cold, so we'll work through this together. We had a lot of discussions about what's going on with our turnover, med surg, critical care, ED, surgery, it was across the board. And we had anecdotal stories from what I'll call residency programs. We all know that term pretty universally. There are different terms for those kinds of coaching programs for new grads. But we had some anecdotal discussions from nurses about incidences of bullying, lateral violence, or incivility. And they were rather troubling to hear. Lisa Sparks is the chief nurse at West, and we talked about what would be meaningful in terms of my graduate work, my DNP work, to do something about turnover that we were experiencing and the stress associated with that and the financial cost associated with that. And we landed on this because of some of those stories that we heard and because of some of what we witnessed ourselves in the clinical environment when we rounded. Nonverbal behaviors, things like that we started to pay attention to. So that's how I landed on looking at nursing incivility and looking at interventions that we might employ to reduce that and then increase our retention, stop losing nurses from the profession entirely, which happens in some instances, and to improve the health of our nurses because it's very stressful. It really takes a toll on them physically and emotionally more than we know, especially from listening to stories of nurses who are in residency type programs. And I've had the honor and privilege to listen to some very difficult stories over the years from nurses who have suffered at the hands of folks who do not know how to coach nurses or how to treat them, especially new nurses, with some kindness, respect, and some education. Is most of the time what they need. So it's a persistent challenge. Civil and respectful communication. We cannot expect to have good outcomes for our patients, and we can't expect to have good outcomes for the nursing profession if we don't have civility in our communications among the healthcare team members. We often talk about interdisciplinary rounds happening now. Interdisciplinary rounds, that communication that happens on that team, and many hospitals have those rounds now, if you don't have the ability to talk back and forth to each other in an open and respectful way, then patient harm can occur. It leads to new graduate burnout. We've talked about that. They can leave the profession, they leave the department, they leave the hospital. The cost of turnover varies widely in the literature, but it's significant. Anywhere from 20,000, I've seen some all the way up to 84,000 per nurse that leaves. It takes a lot of time to orient this staff. It takes time on the unit to build their skill set. And if they leave for anything other than advancing their professional development, that's a big loss for the institution, and it's a loss for the profession and for that nurse. Published survey results, and I've got some of these references in my bibliography. Some of these published surveys with studies, there were actually nurses who talked about incivility events that occurred that precipitated in harm and reduced patient care quality and the safety of care. Laschinger and Leader, they have a lot of the literature, and there's a lot of studies in the literature around this. And they've done a lot of interviews with nurses and have done a number of studies in the area. And so despite all of this awareness, and we've all been talking about eating our young since we were nurses. I'm an old-time nurse. I've been at it more than 30 years. And eating our young has been happening for a long time. And despite all of this awareness, it still happens, both to experienced and inexperienced nurses. And we think about the young and inexperienced nurses being the one that are harmed the most, but experienced nurses can say, I've had enough too. And those are the guys and gals we need at the bedside helping bring on these newer clinicians that are coming on board. Wow, I didn't even do that. I don't have a clicker. Isn't that fun? Okay. Okay, so what is incivility? Clark has a book out on nursing incivility, and it's a wonderful book. It's very good. That's referenced as well. She describes it as a range of rude or disruptive behaviors, or that failing to act when you can act to support a nurse, to prevent a nurse from making an error or from making a mistake in communication, that results in physiological or psychological impact on the person that's involved. Anderson and Pearson have also done a lot of work with incivility, and they've even joined, I believe, in some work. Describe incivility, this one, I like this definition better, a low intensity, kind of rude, discourteous, ambiguous intent to harm a target. Sounds like a bully, doesn't it? So it's disrespectful. In contrast, bullying is real high intensity and with intention to cause harm, if you think of bullies in the playground. But this low intensity, rude incivility, we're talking about nurses who need support or who have questions or that you see is struggling, but you pass them by. They ask a question, you roll your eyes, or you might say, geez, we just went over this yesterday. Not thinking about the process that person needs to learn. I studied a lot of Benner's work, and I've looked at the stages of development for a nurse, from novice to expert, and it takes some time for young novice nurses to have repetitive experience to help them gain their feet and to learn what they're doing in their practice. And I think that piece of education for newer nurses is really, or for preceptors is really very important. They're going to ask a lot of questions, and they need that repetitive experience if they're going to gain that clinical expertise. And it happened again. I don't know what I'm doing. That's all I had. So the literature review. So the literature review was kind of frustrating for me at first. This sounds really loud. So the literature review was kind of frustrating for me. I didn't find a lot in that as I started my project. In a way, I guess that was good because it showed that I needed to do something with it. There were some published tools and methods to counter incivility. There were some studies that really, the one thing that surprised me so much was there was a lot of studies for nursing students and incivility they perceived on the part of their teachers. And probably preceptors as well. I count them as teachers in the clinical environment. So there was a lot of studies of junior and senior nursing students that I found. But I didn't see a lot in the clinical environment where I was at and where I was most interested in. Several interventions were identified as potential methods. One was creating empowering work environments. Cantor's model of empowerment was the background theoretical foundation for this project. I loved looking at that. We'll talk about that a little more. But empowering work environments where nurses have the skills and the ability and the resources to deal with uncivil behavior in the environment was something that a few had studied. And I thought that was interesting for me to look at that. Educational programs, we know that education isn't the be-all and end-all. It depends on the type of education, and it's not the cure-all. I think we go to education a lot just to say, here it is, read this, and don't do it anymore. Kind of isn't as helpful. Leader emotional intelligence is huge. And you know, many of us are in clinical sites still, but to go on a unit and to see, and I've worked in many hospitals, you can tell when a leader has their thumb on the pulse of what's going on in the unit. Whether or not there's civil communication happening, whether or not there's good interpersonal relationships, whether or not they're a team, that they're friends, at least at work, and that they count on each other. And it takes a leader's emotional intelligence to understand what's going on in their hospital, in their unit, in their department, to be able to recognize what's going on so that they can intervene. So there were a few studies that talked about the importance of emotional intelligence. And then the one I landed on that I was really interested in was that of cognitive rehearsal, because in my mind, you can change a culture, you can change the environment that somebody is working in, but it's up to the individual to change their own behaviors and how they relate to other peers, or in how they respond to uncivil comments made in their direction. So to me, looking at, this is just so funny. Looking at cognitive rehearsal, to me, was a way to give power back to those who may be victims, and to help them understand how to put a stop to it. As I mentioned, Cantor's theory of empowerment, formal power and informal power, and the informal power is what really intrigued me in this part of the model, was that anybody can handle what comes their way, be it a staffing situation, an incivility, poor communication, struggling to work with a group of physicians or a group of peers. Knowledge and expertise and having the information they need to do the job is really important. To have the knowledge and skills to be able to do this, and this is where simulation is starting to creep into the literature now, and the expertise to deal with it. Resources, time, material, money. So the time to learn, the time to engage in shared governance. Shared governance is huge for preventing this kind of event in units, because they come together as teams, they're using evidence-based practice. All of those kinds of concepts behind shared governance are going to improve the communication skills and the interactions between nurses. So having the resources to be able to do that is important. That means somebody that can lead a team, time off from the unit to participate, and then the resources meaning, look at that, the resources that mean folks that can help support those evidence-based projects. So when I look at resources being a CNS, I think of expert resources, professional development staff and clinical nurse specialists and managers that can partner with them. And then the support from leaders and peers. So cognitive rehearsal, I read a lot of Griffin's work way back in 2004, it seems like, that she did a lot of work to combat lateral violence. And these are some of the key things that I took out of some of her work that I read in articles that I thought was very interesting. In one study, 96% of nurses surveyed said they had witnessed lateral violence. So described to them in a survey, 96% said, yeah, I've seen that. And I think many of us could say that that's the case as well. 46%, about half of the ones that she surveyed, said it was against me. I recognized that I had experienced it myself. This study was pretty interesting that after the intervention, victims experienced that the lateral violence stopped. So she got some groups together and she did some work with these folks with cue cards, some of what I did in my project. She did some education, she did some cue cards. She identified the top types of incivility, and then she gave them resources to deal with it. How do you deal with it? So after the intervention, they experienced that it stopped. Perpetrators responded in the beginning when they confronted them. I didn't appreciate that comment. I'm asking you how to do this because it's new and I've never given this drug before. Where do you want me to go to get support? If it's not you, tell me where I'm supposed to go. You're my preceptor. That kind of response. Many of them shunned the coworker for a little while, but not for long. They came around. Many of them apologized, and many of them said, I didn't even realize that I was doing that. And we found that, eye rolling, busyness in the unit. Somebody's asking a question, you don't even look at them, you're turning away. They felt that as being, I was being ignored, my needs weren't being met, something I said was bothering you, all kinds of little messages go on in that person's head about why they can't get the response that they're expecting. So I was surprised by that they didn't even see their behavior as being abusive. And many times that's because of the busyness of a unit, the turnover of patients, the churn and burn, as some of us were talking about before this lecture started. And 3 months after the intervention, the tool is administered again. Whoop, shucks, I went too quick. Oh my gosh. Holy cow. Okay, now I'll catch back up. So the cognitive process, so it's very basic. The recipient would take in the negative message when she hears the remark, and what he or she has to do is not focus on the remark and take it personally, easily said than done, but refuses to focus on the personal meaning behind it and responds with new behaviors of the way they would want to be treated, like I just stated. Okay, I'm not supposed to ask you this question. You're clearly angry that I asked this question. I haven't given this drug before, so why don't you tell me who my resource is? And those kinds of, it was respectful, it was direct, and it was designed to get what they needed to take care of that patient or take care of that question. So that was the point of her work, was to teach the recipients, which really sang to me. So that's why this kind of guided what I was going to do with my project. So the purpose was to assess the significance of incivility in the acute care environment before and after an intervention to reduce incivility using the nursing incivility scale. So I wanted to know if those scores would change before and after the intervention. Okay, so the nursing incivility scale, well, we'll talk about the methods. It was a pre-test, post-test design. We used I used the incivility scale in a SurveyMonkey, and it was a SurveyMonkey, a corporate site that was secure. The intervention was distributed via an ELMS module. So this was really tough because, of course, I wanted to do far too much than my project would allow me time for. So Cindy had to drag me back a few times, but we did this. Ended up being an actor-narrated ELMS module. There was some education in it, but then I had some actors in there and I had scenarios. And these folks would have this interaction. I think I had an operating room nurse, an orientee, a nurse afraid to call a doctor in the middle of the night, and some things like that. So they were actually narrated situations. And then by actors. And then I gave them the cue cards on their badge hang tags for the common forms of incivility. In these cue cards, I got permission to do this from the author. And what these cue cards did was not so much pull out your badge and say, I feel bad, what do I want to say to you? But it was more or less a resource for later on. You know, this occurred, that occurred, and they could look at that resource about what was going on and how they could have handled that differently. And then 3 months later, we resubmitted the tool, or resurveyed the folks. So the tool itself, it didn't skip 2 slides, did it? No. The scale, it sets a 1 to 5 Likert scale, like low incivility to high incivility, and measure the perception of incivility from 5 sources. Peers, managers, physicians or providers, the patient family, and then the hospital in general. So I did a paired dependent t-test, and as luck would have it, so this was to be paired. So I had 135 nurses take the pre-survey, and at the beginning of that pre-survey, they were going to have a unique identifier so I could pair up their post-surveys with them. And you see, I only got 14 match pairs on the post-survey. So despite all this hard work, I think they all have troubles with their moms, because I said to them, your mother's maiden name plus the last 2 digits of your cell phone number. So your mother's maiden name and the last 2 digits of your personal cell phone number or home number, whatever phone number you want to use. I had all kinds of numbers in there. I mean, they did it. They put in names and numbers, but I only had 14 matched subjects, which is really unfortunate because that was a great N size of 135. And I thought I might look at, you know, unmatched pairs to see what the differences were, but I just really didn't think the strength would be there. So it's just a few, you know, just 14 nurses, but you can see the demographic data is pretty much spread throughout. There's just a couple of nurses in many of these departments that were matched that took the survey. This was the age distribution. I wasn't surprised by this. 46 to 55 at this hospital, and the experience of greater than 10 years was on the higher end. I think that's an 8 there, 6, 8, yeah. So the experienced nurses we were heavy on, and there were some very tenured nurses at the hospital. So comparing the mean pre-intervention and post-intervention, there was no statistical difference between the 2 groups. That's not shocking because the sample size was so daggone small. What was interesting is the RN experience and the improvement in the coworker scores from nurses with more experience to 0.033. So nurses that had greater than 10 years of experience had a drop in that incivility score with their relationships with coworkers more than nurses with less than 10 years of experience. And, whoops, coworkers. And then the same is true for patients and families. They had a drop in incivility in their relationships or perception of incivility and their interactions with patients and families. So a number of ideas came through about this, and this is really frustrating. The one thing that I presented this at the IU Nursing Research Committee, or research conference, and we had a lot of discussion about why this was so, and many folks felt that it was because the nurses with greater than 10 years of experience had more practice behind them, had more experience behind them. They weren't so interested in looking at the nitty-gritty of their daily nursing practice and their tasks and accomplishing tasks, they were able to absorb that education more, perhaps, than the nurses who were newer in practice. Also, we wonder if those scores didn't improve for the nurses with less than 10 years experience because they had learned something and they were seeing more of it, whereas the experienced nurses had been around the block a few times and they had seen it. But we were building an awareness of what incivility was for those nurses. So there were a couple of things that we thought about in that area. So obviously, further data analysis, a better study design. I don't know what I could do to improve those match pairs, but increasing knowledge and awareness, residencies, new hire orientation. I'll tell you that while I've been working on this project for 3 years, I spent time with some of the residency groups, and I would even present the education, some of the slides about the education, about 6 or 8 months after they've been in practice. And it was interesting to listen to some of their stories. Once we talked about incivility and what it was, and some of the common forms of incivility, they shared quite a bit about how they had experienced it. Some of them didn't recognize it, and others did, quite a few did, because they had experienced it. And it really was cool to see them support each other on some very tough stories. You know, at this hospital, this happened to me, it's not happening to me here. You know, maybe I could have done something different at the prior hospitals. There was a lot of support in that residency group, and I think that could continue on if we maintain that. Mentorship, if newer nurses are less focused on learning, are newer nurses less focused on learning outside of the organization and with clinical mastery? And what role do experienced nurses have in supporting those younger nurses that are more novice, that are entering the department? And again, that's where I say that foundation of empowerment, shared governance and resources and knowledge, that I think that experienced nurses in a unit could do a lot to support those novice nurses on how to handle these kinds of conversations. And some of that was in some of the scenarios we had in the ELMS PowerPoint module that went out to the staff. And we had an experienced nurse in there kind of mentoring the less experienced nurse. So I think there's a role for those experienced nurses, pulling them into shared governance and having them help us lead this work. And then the leadership interventions, you know, empowering environments and emotional intelligence. But I'll tell you, I'm kind of interested in what's next as I learn about this. And obviously the new graduates in residency, I think, are a huge source of learning for this as we go on. Shared leadership engagement is huge. We're going to, we have retreats down in Bloomington. We're going to be having some retreats coming up. Some of them are for leaders, some of them are for direct care staff, PCAs, LPNs, RNs, all of them that come together. And we're looking at what can we provide them to help look at this and be aware of this, and to help coach and understand how to handle this among each other. And then there's this idea recently in an article I read from 2017 on the idea of comportment. And Webster talks about being dignified or having manners or having the ability to convey information. But really what OSHA says is that it's the skill to be able to communicate, manage conflict, have the knowledge in the clinical environment, and most importantly, to show compassion. And there have been, I read some of the references in her article. I looked through some of those because I'm looking for that next step. You know, what can we do, the next step to support Bloomington nurses, but indeed, you know, all of nursing. But what I'm interested in this is to look at how we can, you can't really teach it, but you can coach it by simulation and example. And there was one study that has nurses, senior nurses in school, in their sim lab would actually go into their simulation. They would have, I don't know, somebody with a high heart rate and a low hemoglobin that would pick up the phone, call a provider, and then have a not so nice remark from the provider. You know, why didn't you look at this? Or you know, something that's not so nice, real time in the simulation, and teach them how to handle that and get done what they need to get done for the patient. So again, it's like we talked about with that cognitive work. It's not internalizing it, and I'm telling you, this happened to me in critical care for many years. It's probably why it's near and dear to my heart for this subject. It's taking it personally and then just backing away from it. Well, I'm not going to call that doctor. It's 4 a.m. It can wait 2 more hours. I'll have days handle it. I heard many, many stories in my travels of talking with novice nurses. And I think if we start to build this into their curriculum, that we build it into residencies after graduation, but even into their senior year studies where they've got a little bit behind them about what they're doing and what processes are, but maybe not quite put the whole picture together, they're going to be making those phone calls for 2 years. A nurse doesn't become competent for 3 to 4 years, according to Benner. It can be 3 to 4 years. Some of them make it in 2 if they've had if they've had a healthcare career that's maybe an EMT, or they've been an aide and they've been around patients and they've seen symptoms and things. But it could be a good 3 to 4 years before they reach that competence stage. They're going to be making these phone calls, and they're going to be making these approaches to senior nurses and to physicians on rounds. We need to teach them how to feel confident to handle that on behalf of the patient and for themselves. Because if they feel good about their practice, they're going to thrive and they're going to do a fabulous job. So that's kind of where I'm going with that. And that's it. That's all I had. I am really interested in your thoughts around that. Or is that already happening and I just don't know it? Like the S-bar.
Yeah, right. So, but I mean, it's interesting that you bring this because I think we could do a better job of talking through that piece. But at least we had it in the right direction. Yeah, right.
Awesome. That's awesome. I mean, they were awful